Let's go ahead and get started. As you can tell, I am not Sadeep. Sadeep is away right now. I am Dr. Russell Griffin. I'm another professor in the Department of Epidemiology, PhD program director. So I told Sadeep I would fill in for him. He told me to tell you that if you're registered for this course to please sign your name on the sheet, wherever that may be. I'm assuming it is to my right, but I'm not sure. But there's allegedly a sheet somewhere.
I think it's right.
I can't see it with the wall that's blocking my view. Oh, it's right in front of me. Good. It's a good thing it wasn't a snake then. All right, so today it is my pleasure to introduce Dr. Bertha Hidalgo, who is an associate professor within the Department of Epidemiology here. She's also the associate dean for the Office of Access and Engagement at the University of Alabama, Birmingham. So that's awesome. I've known Bertha for a long time. I actually remember one of the first days you were at UAB. You came to the Cracky building, which is no longer here.
Yeah.
Yeah, I was a PhD student in the Cracky building working in trauma, and you came by to talk to Jerry, I think.
And I asked you a question about regressing to the mean.
Yeah, I don't remember that, but I'm sure it was a very thoughtful question or answer, knowing me. So Bertha graduated from a bachelor's at Stanford University, got a master's in epidemiology and biostatistics, as I just learned, from the University of Southern California. I was going to say South California, but the other USC. We won't talk about them. We're from the South. And then got her PhD in epidemiology from UAB. Again, she and I were kind of in the same PhD process, so I remember her. And then we both joined faculty at UAB. So she has over 100 publications in the area of cardiovascular disease with expertise in genetic epidemiology and dissemination science. And so with that, I will take your leave and open the floor to Bertha.
Thank you, Russell. Thanks. And thanks all for being here. I know that a lot of people are traveling and currently at APHA. So we are not recording this, and actually, well, I think actually we are recording this, but parts of this presentation will not be recorded. I have information that I've put in the presentation just for the purpose of today's seminar. And so if you watch the recording, you may miss some of that. But that's okay. Nevertheless, I had a variety of topics from which I could choose to present on. I see Ryan in the audience, and Ryan and I do a lot of genetic epidemiology, and oftentimes for these types of seminars, I find that our topic sort of like is a little too niche. And so part of what I do is a lot of science communication and science dissemination work. And thought I would talk about that today. I've also been asked to share a little bit about my career trajectory, especially for the students in the room, so we'll start there today. I have no disclosures. As I was looking for past examples of my career trajectory, I found a couple of slides. Here is one that starts down in 2000. I just had my 25th college reunion, which feels so bizarre to say, but I just was on campus at Stanford University for that 25th reunion. One of the things I did as a high school student was attend a meeting. I think it was a scientific meeting. I can't recall exactly how I found out about it or why I made it there, but all I remember is that the NIH, the National Institutes of Health, had a booth, and they had people representing the undergraduate scholarship program, UGSP. And I went up to the people in the booth and I said, I'm applying for colleges and I'm looking for scholarship money. And they said, well, we have this really interesting program where you come and do research during the summers of your four-year college experience. And then you have to come back to NIH once you graduate for a payback. So I did a post-bac at the National Institute of Allergy and Infectious Diseases with Tony Fauci from 2000 to 2002. And that I interviewed with several labs after graduation, and Dr. Fauci's lab picked me and I picked him among my top three. And so we were a match. And I spent 2 years in the laboratory of immunoregulation, studying the effects of short intermittent heart therapy for patients with HIV. And it was that experience that made me realize I did not want to do bench science research. and but also I think I was on the pre-med track until this time and decided then also that med school was not something I wanted to pursue. I really enjoyed being on NIH campus and aspired to reach more people than I thought that I could in on a one-on-one basis if I went to med school and like worked in a primary care clinic or something. So I learned about a master's in public health just through a flyer. Someone posted a flyer while I was working at UCLA as a program coordinator. And this was after I'd returned to LA, after I'd completed my postbac and was sort of trying to like figure out what happens next. And I didn't know how things worked. So I emailed the dean of the school and I said, I think I'm interested in your program. Will you meet with me? And it was Tom Valente, who was the dean of the School of Public Health at USC at the time. And he said, sure, come on down. And I told him a little bit about myself, and he said, yeah, you should apply. And I applied and I got in. And quickly realized that USC was $50,000 a year at the time for a master's program. And so I thought, well, I can't spend 2 or more years in a master's program because I already had debt from Stanford, despite the scholarship that NIH had given me. And so I finished my master's in 3 semesters. I was working so hard to make sure that I got through all of my coursework and I could graduate so that I could complete that. While at USC, I fell in love with epi. I didn't know anything about epidemiology. I'd never heard of epidemiology until I joined the master's program at USC. And my biostats professor was David Conti. I don't know if any in this room know David Conti. Okay, yes, yeah. So David Conti, actually, and Hemant Tiwari, who's not in the room today, but he's in biostatistics, were very close collaborators. And he said, you know, I think you'd be good for a PhD program. And I said, yeah, I think so too. What does that mean? And so he said, apply to this program because at the time I was married and my husband had moved to Alabama. He said, and I'll connect you with Hemant. So one of the very first people that I met at UAB was Hemant because of David Conti, who still is, I believe, at USC, and he does a lot of genomics and Alzheimer's and brain health disease. At the same time, so I got in when Jerry McGuinn was program director. And I remember I was working as a program manager. I had a full-time job, and he called me and he said, we'd like to admit you to the program. You have funding, right? And I said, yes, I have educational credits. And so I paid my way through the PhD program, but was a really interesting experience because it allowed me to sort of see the ins and outs of research through my program manager work, while also learning the ins and outs of epidemiology through the PhD program. I then had the opportunity to do a postdoc here in statistical genetics. I worked with, that's when I met Ryan in 2012. I was between a postdoc and T32, on a T32 for cardiovascular disease at the Chan, and one here in statistical genetics. I think the other one I was considering was the NORC. But I had one kid, and the postdoc at Harvard was going to pay $3,000 a month, I think, in a stipend. And daycare was just about all of my stipend that I was going to get as a postdoc. And David Allison, who then ran the section on statistical genetics and this T32, said, this could be a really good opportunity for you to learn something new. I didn't know anything about genomics. I think the last genetics class I had taken was in college back in 2000. And he said, but you know, now would be a good time to add a new skill set to your toolbox. So I said, sure. So I applied, they admitted me, and I spent 2 years training with Ryan and Donna Arnett, who's no longer here, but Pat's provost at the University of South Carolina, the other USC. And then I joined the faculty in 2014. It says to 2019 because I then got promoted to associate professor. And then there are these other sort of like really wonderful experiences that have marked my path in dissemination, science, and science communication, including one that you see here, which says Board of External Experts, NHLBI. That was in 2017. In 2017, Gary Gibbons, Institute Director of the NHLBI, came to campus. And I was invited to sit at one of the tables, one of the meetings where he was, I don't know, I think it was Tim Garvey or other people over at the North. And I remember very distinctly, we're sitting around this big conference table, and I'd always had this idea that as I was coming up, one of the experiences I had was that I was becoming very assimilated to academia, the way we speak, the scientific terms that we use, the way in which we publish, the way in which we operate in settings. But I was becoming very disassociated from the way in which I communicated with my family. And I was having actually a really hard time communicating to them what it was that I do as an epidemiologist. And my parents just said to their friends, she works at a university, we don't really know what she does. And so I don't think that I was doing a good enough job. So I said at that table, I said, you know, I don't think we do a good enough job as scientists communicating our findings to the general public. We are very insular and siloed in the way in which we communicate. We have these really fantastic findings, and then we publish in a journal, or we go to a scientific meeting where the public is not present. It's actually very cost prohibitive, even for some scientists, to attend some of these meetings. And so we don't do a good enough job of communicating. That's what I think led him to, on a Friday afternoon at 3 o'clock, send me an email from his iPad, which he's notorious for using, to say, I'd like to invite you to be one of the experts on my board of external advisors. And I was floored. I thought it was spam, actually, so I just ignored it. But it's really set me on this path of trying to understand how it is that we communicate epidemiology, specifically because I'm an epidemiologist, to the general public, so that we can advance innovation, discovery, but also understanding of the science that we work so hard to produce. This was one of the presentations, one of the slides I included in a presentation when I got my K award, and I think I was presenting to my committee. And it's much more granular. Like in 2016, I had 32 publications, 10 of those were first author. I'd had a diversity supplement, a pilot award. I got a loan repayment program award in 2013 as a postdoc. It was sort of like laying the foundation for evidence that this is why I should be a funded scientist, and this is why you should support me. And it's really led to a flurry of now positions and collaborations, and I'm not going to list the grants that have gotten me here today, but really the ways in which I've been shaped to take on some of these leadership positions. So in 2023, I assumed the office of Associate Dean for the Office of Equity, Diversity, Equity, and Inclusion. The next year, we closed that office. We opened an Office of Access and Engagement, for which I'm Associate Dean now. And then in September of this year, I became president of the American College of Epidemiology. In some ways, because of the work I've done in science communication, in addition to the work that has been published in the literature as well. What you probably won't see on my CV are some of these experiences. So I have done a lot of media, especially since 2020, the start of the COVID pandemic. I had my first foray in the non-science world, publications, journals, pieces, when I made the cover somehow of Redbook magazine in I don't even know what the date was. I have been an avid user of social media for some time, and I sort of would share my journey as a graduate student and then postdoc, and then when I finally made faculty. And I used to share these tips on how to put a professional suit together for your interview for $8. And people really liked the content. And I was invited to fly to New York to Hearst Towers and have this like whole photo shoot with these two women, and then there were three others, and talk about my experience as being a mother, a scientist, but also a communicator on social media. That led me to a number of other opportunities, many opportunities which have happened on Spanish language media. If you speak another language and you're an epidemiologist or you're in public health, there is a huge need for disseminating science in other languages. And this was very evident during the COVID-19 pandemic as well. So much so that in, now I can't remember the dates, they're evading me. 2022 and 2023. This is America Ferrera on the very left. And she and a group of others like Eva Longoria and other Latinas that are sort of in the media space somehow plucked me out of the social media space and said, "You've been doing really good work, and we need someone to give a brief on the state of Hispanic health in the state of Alabama and all that you've done for the COVID-19 pandemic communication. Would you be willing to come and give us a brief at the White House?" And so I just gave a TED Talk in Gulf Shores on Friday, and I titled it "Do It Scared." Because many of the opportunities that I've done, especially in communications, because I went into epidemiology specifically because I am introverted by nature. And I like to sit in my office, and I like to do my work, and I like to be left alone. But I feel called to do some of these things, and so I said yes. And this was me on the right during that visit. We got to tour the entire White House. I gave my briefing, and it was just a really wonderful experience. And then the following year, both in part because of that briefing and because of the work that I'd done during the pandemic, I was invited back. So the middle picture is the celebration where I was awarded a Hometown Hero Award by the White House for the work that had been done over the course of those years. The work that I did on social media, though, has shown me that facts alone don't change minds, and that trusted messengers do. If any of you do community-based participatory research, you may know that this is very true on the ground. You can't just tell someone that what you study is fact. And oftentimes, even if you do, they may not believe you. And so these are a couple of the moments where I realized that credentials were not enough. In 2019 and from 2019 and before, I was on social media as chic in academia because I told you that I shared sort of like sartorial content. I was sharing my experience in academia, and this was into 2020 where I was still chic in academia on social media, and I thought, who's going to believe COVID-19 communication from a chic in academia account, right? It was chic in academia for years because the early advice I got from mentors was that if I disclosed who I was and I sort of owned this non-academic, non-scientific persona, that I would not be taken seriously in the academy. And so I tried for many years to be quite anonymous. My name wasn't anywhere. It was this sort of like, what do you call it? A pseudonym, like a ghostwriter type title, right? And then eventually when I got a lot of press, my name was out there. So now my name was linked to chic in academia. But when the pandemic started and I started sharing COVID-19 information, I thought I have to change my name to Dr. Bertha Hidalgo because that's the only way in which people will trust me. And boy, was I wrong. All of my social media handles have some version of Bertha Hidalgo or Dr. Bertha Hidalgo. Very early on in the pandemic, there were two messages that came across very clearly that people bought into very quickly. hydroxychloroquine or ivermectin are effective COVID treatments. Drinking or injecting bleach, alcohol, or other disinfectants will kill the virus inside your body. 2 years ago, I was in an Uber, and the man said to me, ivermectin is what cures me of COVID every time that I get it. Other messages that were out there that really just went viral and rampant through online and in-person communities. It's not just the flu, or it's actually just the flu. It's just like the flu. It's not any more serious than that, especially early on in the pandemic. It's not a real virus. Asymptomatic people can't spread it. Only older people are at risk. So, why should I care? I'm 30, I'm healthy, I'm fine. Weather stops the virus. So as soon as it gets warm, we're fine. If you attend the Public Health Weekly report, you know that COVID has a bimodal distribution. So there's a peak in the summer and then there's a peak in the winter. This was a great one. 5G networks spread the virus. 5G was just coming on around that time. And so there was this belief that 5G spread the virus. That other types of vaccines, like for pneumonia and flu, also protected you against COVID. So there was no reason to get the COVID vaccine. There were other ones that I didn't include on here, like the COVID-19 vaccine made you magnetic. Or there was like magnetism. And that the virus was made in a lab. I intentionally put this one at the bottom because there is still, even in academic spaces, a lot of discussion around whether or not it was. The overwhelming evidence points to the fact that it was not made in a lab. It was not intentionally made as a bioterrorism tool. But it's at the end because that's one that is under active consideration. Then I had a couple moments where I realized that data wasn't enough. Early on in the pandemic as well, there were statements like the government is exaggerating COVID-19 deaths. This was often tied to this misinterpretation of a CDC report that stated that a low percentage of death certificates listed only COVID-19 as a condition. And what fact checkers were sharing was that the most severe cases involve comorbidities, right? Like for those of you studying public health and epidemiology specifically, you know that there are things that can contribute to illness or more severe outcomes, including death. And so symptoms like respiratory failure or underlying conditions like heart disease may contribute to a death in COVID-19. So it may not be listed as died of COVID-19, right? Maybe they had COVID-19 and died of something else, but COVID-19 may have been the exacerbation. More cases are only being reported because we're testing more, this idea that you're only finding them because you're looking for them. But in public health, we were communicating that the percentage of positive cases and hospitalizations was also increasing. So therefore, your denominator is growing as much as your numerator is. Only the old and vulnerable die from it, and then COVID-19 is also just like a bad flu season. This was also happening on, let's say, like the non-misinformation side, where death counts are underreported. And this report on this new analysis reveals many excess deaths attributed to natural causes are actually undercounted. COVID-19 deaths was an interesting write-up of explaining the ways in which early information suggested that the many deaths from natural cases were unrecognized COVID-19 cases. And this really led to an underestimation of the effect of the pandemic. What I also realized was that I had data, but people wanted reassurance and not statistics. And so data does not mean persuasion. You can't show a non-epidemiologist a chart or a plot or a table 1 or a table 2 and then say, you're right. The odds are greater for X person versus Y person. And so information is not communication. How many of us like to present to big groups? So 2 out of what, 30 people? How many of us enjoy talking statistics with non-public health people. George and Jenny. Okay, maybe Craig also. Yes. So these public health bodies contain a lot of information. But unless we share it, it's contained within either ourselves or our microenvironments or our micro communities, right? And because we're so reluctant, either based on personality or environment or what have you, have a really hard time moving that forward. You know who doesn't have a hard time moving things forward is people who have conversations on the daily with their neighbors and their, families and what have you, and may unknowingly be sharing information that is not fact or evidence-based. Producing evidence is not the same as communicating. Misinformation spreads faster than peer review is another statement I like. I shared this a lot during the COVID-19 pandemic related to COVID-19 misinformation specifically, because we're all subject to the spread of misinformation simply by reading a headline and not reading the article and then saying, hey, this may be of interest to you, but actually it may not be saying what you think it's saying, right? Because we didn't read the entire article. And unfortunately, we're being out-communicated. So I'm here to argue that we're in a new frontier of epidemiology and epidemiologic responsibility, that we operate now inside an information ecosystem, that we're responsible for translation, not just analysis. And I put an asterisk on this because some of you may argue, well, we do translate our findings. Yes, but to whom and for whom, right? We put them in a journal, we put them in a scientific presentation. We may put it on a flyer and distribute to local communities potentially. But we don't do a good enough job of translating for all audiences beyond our usual norms. We have epidemiologic citizenship, so that's evidence and accessibility and trust all in one. So we're no longer just generators of evidence, we're translators of evidence in a world where misinformation moves faster than peer review. That's just a re-emphasis there. I also like to share with people the difference between misinformation and disinformation and the way in which relationships are greater and more important than facts, and how engaging in public discourse is a critical responsibility of public health practitioners. We receive funding from the National Institutes of Health. Taxpayers pay money so that the National Institutes of Health can be funded. So it is our taxpayer responsibility payback, if you will, right? Like to be able to disseminate information to them in a timely manner, in a way they can understand it. Misinformation, disinformation, and malinformation are interconnected, but they are very different. So misinformation makes this false connection between X and Y. It may be misleading content. Disinformation involves a little bit more intention, right? So misinformation may be, here's the headline, and I didn't read the article, but I think it's the right message I want to share with you, and I saw it on Facebook, and I'm going to quickly send it in a text or a Facebook message or what have you. We maybe unknowingly contributed to misinformation there. Disinformation involves imposter content, manipulated content, or fabricated content with the intention to sort of deceive, right? And so that's a little bit more malicious. The most malicious of the three is malinformation, where you have leaks or harassment or hate speech, where you're intentionally trying to make sure that you're sort of confusing people. Science literacy is really important. There was this really interesting article in The Atlantic, I think we covered it in Public Health Weekly report, on the growing illiteracy that's happening in America. And there's literacy like being able to read and write and that sort of thing, right? But then there's also health literacy. And health literacy is really tricky because even we as scientists may not understand information that is shared if it is not in a topic area that is of interest to us or that we're experts in. And so health literacy is something that I think we all may suffer from and can benefit from improving. So to those of you, especially the students in the room, I ask you to evaluate your sources. And actually, Dr. Pavella, who's in the audience here today, shared some of the MPH, Masters of Public Health Foundational Competencies, and two are very related to this very topic. So you should ask anytime that you receive information, who generated this data? Who benefits from this interpretation? Is it peer reviewed? I've shared in the Public Health Weekly Report that Robert Malone, I don't know if anyone's familiar with that name, is a good friend of RFK Jr. And he and some friends created what looked to be a journal publication on using actually Florida Medicaid data, where they made this connection, this causal connection between vaccines and autism. And they created a WordPress site where they published the paper and put it out for people to see, so that if someone said, oh, vaccines don't cause autism, then someone who does believe vaccines cause autism could say, well, here's the paper that shows it. And they use Florida Medicaid data, right? And so colleagues and I, who are part of the Evidence Collective, it's a group of science communicators, and we write congressional briefs and sort of help debunk things that are out online, wrote a debunking of the study, sort of like one would do in a journal article, and letter to the editor, or a response to an article. And that debunking I've shared made it into the RFK Jr. congressional hearings. It's important for us all to critique what is online with a really eagle eye. Make sure there are no red flags in the methodology, or that there's no agenda-driven framing. There's no uncertainty in what's being communicated. So epidemiology, I think, is no longer only a scientific discipline. It is a communication profession, whether we like it or not. Because facts don't change minds. There's cognitive bias in all of us. Either for identity protection or for other reasons, people really filter data through beliefs and not logic. And I have learned that, especially when things are really dire, we operate through this sort of lens and place of emotion. And so it's really hard to absorb information through logic and actually deduce and make decisions based on logic as well. And this last part, I think, is really important because people don't often lack information. We're in an infodemic of sorts. That's a term that became really popular during the pandemic, that there's so much information. There's information if you Google, if you're on Facebook, if you're on Instagram, if you're on Snapchat, if you're on email. I mean, there's just this overwhelming load of information. And so it's really hard for people to discern on a daily basis what to believe and not to believe. This happened to me on TikTok. Has anybody seen a video of rabbits jumping on a trampoline? You have? What'd you think of it?
Incredibly believable.
Yeah, but it's AI.
Yeah.
It's AI, and it's a trampoline in somebody's backyard, and there are like 10 or 12 rabbits just happily bouncing on the trampoline. And I thought, gosh, that's so fun, right? So all these rabbits ended up in this person's backyard. And they're jumping on the kids' trampoline, only to find out that it was AI. I got duped. And I have a pretty keen eagle eye for information online, including video content. But that's the thing, is that media is evolving so quickly that it's really hard to discern. All right, how are we doing on time? We're doing okay. All right, so shared information creates social bonds. When people share information, accurate or not, they signal membership in a group. So for example, fans of sports teams. My Dodgers just won, by the way. Congratulations to us. Members of a professional society, like, many of us belong to the American Heart Association, and or the American Cancer Society, or what have you. And there's like a bond that's created through that. We all feel connected. We speak the same language. In public health during the pandemic, it was like flatten the curve, or the RO created a sense of collective action and purpose. I actually had someone sent me a bobblehead of Tony Fauci going like this, like flatten the curve, everybody. But misinformation can strengthen in-group identity too. So misinformation is often sticky, not just because it sounds compelling, but because accepting it can be a badge of belonging. And so in communities where institutions like government, science, and media are distrusted, rejecting this information can be a marker of loyalty. So believing and reposting vaccine myths signals I'm a part of the group that doesn't trust big pharma or government, for example. It also leads to this emotional connection and bonding. Emotional in that you may say, for example, oh, you feel this too. Oh, you believe this too. Yes, and therefore we must be part of the same group. We are the people who know X. There's also the sense of belonging in that we're the only ones who know a certain thing or about a certain thing. Or we follow evidence-based public health. We're a group and we're exclusionary of others. We know the truth that the government won't tell you. That's another group that's out there, right? This belief that we're bound by the idea that someone is against us and sort of out to get us. Silence and isolation fuel misinformation bonded communities. People feel ignored, dismissed, and condescended to. In academia, we sort of do this, right? We're kind of condescending in the way in which we communicate our information. The fact that we forget what it's like to not know information about, for example, principles like correlation does not equal causation. How do you explain correlation does not equal causation? Or how do you explain causation to someone who's not in public health?
And I'm just, thank you.
Do you want to volunteer? How would you explain causation to someone with no public health background?
I think the first thing I would try to do is explain association before I got to causation.
And what is association?
Okay, that is two things that are happening together, not necessarily related to each other. For example, wait a minute, let me get straight. The street temperature in Tokyo is related to birth rates in the United States almost perfectly. I do not believe that those are causally related. I think that's some association. When you look at a large number of factors, there'll be some that are associated by chance alone and not causally related.
Yeah.
And make sure they're comfortable with the fact that two things being related does not mean they cause each other.
Right.
When my watch says 3 o'clock, clock chimes.
Is that right? Is that causal?
That my watch is not causing that clock chime.
Yeah. I also give the example in the summer, you see ice cream sales skyrocket, but crime due to gun violence also increases quite exponentially in the summer months. There's actually this whole like psychology behind why, right? And so do ice cream sales cause firearm related deaths during the summer? So, but that's hard to have in a 10-minute, 10-second interaction with someone, right? So correct information can also build belonging. We're trying to do that a little bit here through the Public Health Weekly report that we have every Wednesday from 1 to 2, and here in this very room, to foster a way of shared thinking, but also talk through the pieces where they don't quite make sense. Because community is also within our schools. It's not just out there, outside the building, outside the university. This is an important concept, illusionary truth effect. Also known as the illusion of truth, describes how, when we hear the same false information repeated again and again, we often come to believe it is true. Does anybody have a good example of this that you've heard in your own circles? I have one I can share.
Well, I have one.
Kelly.
You need to walk 10,000 steps per day.
Yes, that's a good one, which I do. Which I do, but that's a good one. Yes, Greg.
Maybe you've heard the same one, so I've heard about the body temperature of a chicken is something like 180 degrees. And so if you repeat the right number of the chicken, some ridiculous number, people will tend to believe that is the body temperature of a chicken.
Okay, yeah, so the body temperature of a chicken is 180 degrees is another one. In our immediate like family circles, it was that if you walk out with wet hair, you would catch a cold, right? That's another sort of one that has gone through generations in our family. And so this repeating pattern is something that some groups do very well to make these ideas sort of believable among populations. People don't just share information to spread facts, they share it to signal who they are, who they trust, and where they belong. And misinformation can't be solved by data alone. I hope that I've convinced you of that. So what do? To learn how to communicate, there are some basic tenets that we can follow, and I actually have some ASPPH slides that I can send separately that are included in this presentation, but we may not have time to go through so that we can allow for question and answer. But it's really important for us to understand who our audience is at any given moment. And that while, yes, to be in academia and to be in scientific circles and be perceived as serious and knowledgeable and really accomplished, scientific terms and really long words and beautiful English spoken language is necessary, or maybe language spoken in any other language with big fancy scientific terms. But the best communicators are people who can break it down to very simple language. And at this time, when we're suffering from an infodemic and we're suffering from high illiteracy and high health illiteracy, it's really important for us to learn how to communicate in that way. Storytelling is another really powerful way to do this. And so people are motivated through emotion. Oftentimes we hear, and actually we did an American Heart Association funded study on this, to understand how people make decisions about whether or not they participate in heart health research, but just in research generally. And there were two big themes that arose. One is, if the story that's being told matches how I feel emotionally, or it makes me emote in some way, right? It makes me sad or happy or whatever, then I'm more likely to be called to participate in research. The other is, and this was a really funny response to see on the survey, and that was, Dr. Bertha Hidalgo told me to. Which is either really worrisome, right? Because they perceived me as an influencer in the social media space, or it really signals that trust really matters. Values alignment, pre-bunking, this we haven't had a lot of success with in this group of science communicators that we belong to, the pre-bunking, where you sort of put information out there and, hey, be on the lookout, there's going to be this information about saturated fats. It sort of like misses people. We don't find that the pre-bunking works that well, but it could be one way in which to communicate information and sort of get ahead of it. Visual literacy and explainer formats. So I tried to do this during the COVID-19 pandemic quite a bit, where I tried to break the science down as much as I could, even talk about things like, what does efficacy mean? This is a good like hat tip to the Howards, right? For all the clinical trial work that they've done over the years, and tried to explain how you do the math for to understand how efficacy works. What is COVID-19? Like we say COVID, but what does it stand for? And why is it 19 and not some other random number? It showed what the lineage was. Hey, this is a whole family of viruses, and COVID-19 is one of the cousins that decided to make an appearance and like rock our worlds, right? How coronaviruses work, that it's part of this family, and there are other family members like MERS and SARS that also contributed to symptoms that were very related to COVID-19. This was a favorite of mine because it showed the SARS-CoV-2, the coronavirus, are these balls that are protected by proteins, and they're stuck together with like grease, let's say, right? If you sort of just want to break it down. And the reason why washing your hands works so well is because it sort of breaks apart the virus, and then it allows it to no longer be around. And I don't know if you remember us singing happy birthday as we washed our hands for some time. This I loved. This was one of my favorite ways to explain why SARS-CoV-2 affected all organs in the body. And so great moments for education happened during the COVID-19 pandemic. And for me personally, also showed me how information is received by people, that you really need to target the different ways in which people learn. Some people are auditory learners. Some people are visual learners. Some people need to read, right, and process, and then say whether or not they read the information. We'll do this quickly, and I think we're gonna actually have to close so that we can have some discussion. But I wanted to present this to you because it is in the news this week. So Tylenol causing autism ? Autism linked to Tylenol. Is this headline misleading? Tell me more.
It's another instance of association due to, or based on the research that's available at this time, the actual link is to elevated body temp during pregnancy, not necessarily Tylenol. But what do we take Tylenol for? We take Tylenol for fevers. So they are drawing conclusions based on the Tylenol usage instead of what's the actual cause for concern.
So how would you fix this title?
Very good question.
Others? It's hard, right? And some of these reporters are writing on timelines, like very quick turnaround timelines. I remember during the pandemic getting calls from the New York Times at 5:07 saying the story goes live in 20 minutes. Can I get a statement? So it's hard. It's really hard. And especially when science, it needs to be communicated in such a way that the reporter themselves also needs to understand, right? So some of these titles may not be misinformation intentionally, but they are, unfortunately, misinforming at times the public. Okay, but there are two foundational competencies in your Masters of Public Health program that is going to be really important for you to think about as you make your way through the program. The first is assess the quality of data sources for potential bias or misinformation. This may or may not be a competency that you achieve in all courses. However, there will be courses in which this will be really important for you to assess, but a skill that you need to take beyond your coursework. The second one is FC16, apply communication strategies to address public health disinformation or misinformation, the very thing we're talking about today. And that can be really difficult to do. I will tell you that part of the reason why at the beginning of my social media journey, I was okay with not putting Dr. Bertha Hidalgo on social media is because I did not feel comfortable in my own PhD shoes yet. I did not feel like I could be the authority or voice on scientific and public health topics. Who was I, this new PhD, this postdoc, this early career assistant professor, to share information when there are, people who could do this much better than I? But you're skilled at discerning information. You're skilled at connecting with others who can vet the information that you want to share. And so what have we learned about science during our short tenures in the master's and PhD and other programs in this school? Hopefully you've learned that science is not a me sport, that it is really based on teamwork, and that you have groups of people around you that can help you be effective disseminators and communicators of information. And so if you walk away with nothing else, I hope that you walk away empowered to fulfill the competencies of your program, but also to step into some form of communication in the next few days, weeks, or years to come. So with that, I think I'll close. Thank you. Any questions or comments? Russell left the room. Yes, Dr. Cody.
Well, fantastic presentations. It's really great, a lot of fun. So communication is a skill that takes practice, like all of our scientific training or methodology skills. Do you have suggestions for people getting started in their communications journey in terms of like where to start, resources, or ways to practice their communication skills?
Yes. So UAB Communications has media training that is available to individuals and or schools. If there is enough interest, we can bring them to the school. Actually, we have a session coming up that has been requested by some faculty. There's also the Public Health Communications Collective, and they share, I don't know if it's weekly or monthly, but they share information on how to communicate about things like vaccine, maternal health, respiratory viruses, etc. If you want to go one step further, the Ellen Alda Center has also great communication workshops. I think Emily and I did one when they came to UAB last. That's a fantastic one. One other piece that I forgot, so Donna Arnett, when she was president of the American Heart Association, we were at an American Heart Association meeting and I was presenting a poster, and she walked up to me and she said, "Tell me about your poster in 4 seconds." Or maybe it was 10. And at the time, I had a really hard time saying what it was that I did research-wise, like what I was working on in less than like 10 minutes or something lengthy, right? I was very like wordy. I had a really hard time communicating. I still am not perfect, but that was another reason to go into it. So I would say like those are some of the resources that are available. There are other workshops that I can share, but those are the ones that come to mind.
You know, the other problem with the short sound bites is you don't get to talk about the limitations. There's no such thing as a perfect study.
Yes.
You know, so when you talk to the media, they want to cut to the chase and say, what did you find? But it's limitations.
Yes, the nuance of science is really hard to communicate. Do you have a related point? No. Yes, and so what I have found is that it is really important for us to practice what our bottom line is. That will also not be misinterpreted if it ends up as a sound bite in the media. And actually, I pulled up some UAB media communication, media training slides from 2016 that show you exactly how to do that. So David Ellison actually got in a lot of trouble for this because he did an interview with Katie Couric. I don't know if y'all remember this, but some of the snippets that were taken to piece together his interview made him sound really, really bad. And that is a danger. There are ways in which you can protect yourself. So for example, I always ask in advance, will you allow me to see the piece and my quote in your article before you go to publish? A lot of reporters do not like to do that because they're afraid that you're gonna like share with other people. But other papers like The Atlantic are more willing. And so then you have to choose who to go to. I'm gonna go to Ryan just because we've got a minute left.
Well, I was just gonna say, I think it's a field we need to come up with some way to sort of, internally score our our research outputs, that there's some sort of a metric, like this got 5 stars or this got 3 stars, because it's really, we can't ask the public to go in and pick out what's the best publication.
Yeah.
Or what's the best study, or what's the best design study, or whatever. We can't ask them to do that. And we flood them with papers, and they come and they find, they'll pull out, like this. The Tylenol is a perfect example, of some smaller study kind of driving, a consensus that most of us don't really agree with, right?
Yeah.
And so, like, how do we keep that from happening? I think like that's like a reconciliation that we need to come up, as a field.
Agreed. Yeah, and there are places like George Washington University that write it into their promotion and tenure guidelines. did your work get picked up by the New York Times or, what have you? And that has some weight in whether or not the impact of your work is significant. I would argue also for those of us that teach that it's really important for us to, yes, share the very nuanced way in which we're interpreting data, but then say if you had to give a one-line summary to someone in the community, this is what we would say. And that's really hard to do in like biostatistics or even epidemiology. But to the extent that we can start to work towards that, I think is going to be really important. So we're a minute past. I think we might, I don't know if there are people waiting, but I'm happy to stick around and answer questions. Thank you all for being engaged and being here today. And we'll share the slides. I think Sadeep's online so that people can have them if interested. Thank you, everyone.